Dear colleagues, as the topic of today's lecture will be preeclampsia, this is one of the most serious and common complications of pregnancy. Hypertensive disorders complicate 5 to 10% of all pregnancies, and these disorders are one member of deadly triad, so-called deadly triad, along with hemorrhage and infection, that contributes greatly to maternal morbidity and mortality. Of this disease, of these disorders, the preeclampsia or preeclampsia syndrome, either alone or superimposed on chronic hypertension, is the most dangerous. As subsequently discussed, new onset hypertension during pregnancy, termed gestational hypertension, is followed by signs and symptoms of preeclampsia almost half the time, and preeclampsia is identified in 3.9 to 5% of all pregnancies. Importantly, this classification differentiates the preeclampsia syndrome from other hypertensive disorders because it's potentially more ominous. This concept aids interruption of studies, interpretation of studies that address the etiology, pathogenesis, and clinical management of pregnancy-related hypertensive disorders. So, preeclampsia. Preeclampsia is a disorder of vasospirituovascular endothelial malfunction and vasospasm that occurs after a 12 weeks gestation in the second half of pregnancy. Note, in the second half of pregnancy. And can present as late as 4th to 6 weeks postpartum. It's clinically defined by hypertension and proteinuria with or without pathologic edema, and multiple organ or polysystemic dysfunction or failure. Gestational hypertension or gestational arterial hypertension is a pregnancy-induced increase of blood pressure, first recorded after the 20th weeks of pregnancy and not accompanied by proteinuria. This diagnosis is made in women whose blood pressures reach 140 to 90 millimeter or greater for the first time after mid-pregnancy, after 20 weeks, but in whom proteinuria is not identified. Almost half of these women subsequently develop preeclampsia syndrome, which includes findings such as headaches or epigastric pain, proteinuria, and thrombocytopenia. Even so, when blood pressure increases appreciably, it's dangerous to both mother and fetus to ignore this rise only because proteinuria has not yet developed. The diagnosis of gestational hypertension can be made only during pregnancy if elevated blood pressure persists by the end of 11 or 12 weeks after delivery. The diagnosis gestational hypertension is changed to the diagnosis chronic hypertension or chronic hypertonic disease in Russia. Maybe primary, maybe secondary hypertension. Chronic arterial hypertension develops before pregnancy or before the 20 weeks of pregnancy. In Russia, it's called hypotension or hypertension disease. Arterial hypertension, which manifested after the second half of pregnancy but did not disappear after childbirth within 3 months, is called classified as chronic hypertension retrospectively. In some women with chronic hypertension, the blood pressure increased to previously abnormal levels, and this is typically after 24 weeks if new onset of worsening baseline hypertension is accompanied by new onset, then superimposed preeclampsia is diagnosed compared with pure preeclampsia. Superimposed preeclampsia commonly develops early in pregnancy. It also tends to be more severe and often is accompanied by fetal growth restriction or fetal growth retardation. Preeclampsia is the first complication of pregnancy that we discuss with students, because this topic is one of the most relevant, as it's one of the leading causes of the structure of maternal morbidity and mortality. Maternal mortality: every 1 minute and 40 seconds a woman dies in the world during pregnancy, childbirth, of the postpartum period. 94% of all maternal deaths occur in the third world countries, low and low middle income, and maternal mortality decreased by 38 from 2000 to 2017. If we look at the structure of maternal mortality, we will see that every 8th or 10th woman in this structure dies just like because of hypertensive complication of pregnancy, hypertension, 14% in structure of main causes of maternal mortality. And preeclampsia took second or fourth place in the structure causes of maternal mortality in the last 10 years. Let's consider the main complication of preeclampsia: fetal death, respiratory distress syndrome, placental abruption, liver and renal failure, retinal hemorrhage, detachment, brain hemorrhage, HELLP syndrome, we will talk about it later, cerebral edema, acute fatty liver. And don't forget about the fetus as a patient, causes of perinatal mortality in preeclampsia: placental abruption, severe intrauterine hypoxia, growth retardation, restriction, and postnatal hypoxia. Complication of preeclampsia: hepatic changes in women with fetal eclampsia were described in 1856 by Virchow. The characteristic lesions were regions of periportal hemorrhage in the liver periphery. On the presented slide, you can see cut age of liver from 36-week pregnant woman with severe preeclampsia. There are numerous areas of hemorrhagic infarction from the parenchyma and the surface on the liver. Subcapsular hematoma in patient with HELLP syndrome. On the presented slide, you can see abdominal CT scan showing subcapsular liver hematoma with areas of increased attenuation consistent with oxygenizing blood. This autopsy brain slide shows the fatal hypertensive hemorrhage in prima gravida with eclampsia. Composite illustration showing location of several hemorrhages and petecha in women with eclampsia, periarachnoid, cortical, subcortical, midbrain hemorrhages in women with preeclampsia and eclampsia. Cranial magnetic resonance image down 3 days postpartum in a woman with eclampsia and HELLP syndrome. A neurovisual defect in this case persisted at about 1 year, causing job disability. Scotomata, blurred vision, or diplopia are common with severe preeclampsia and eclampsia. In the A, puncture retinopathy caused by a choroidal ischemia. In a preeclampsia syndrome, ophthalmoscopy shows scattered yellowish opaque lesions of the retina showed by areas. The late phase of fluorescein angiography shows areas of intense hyperfluorescence representing pooling or extravasated dye. Another problem is a social problem with preeclampsia: treatment of premature newborn born to a woman with severe preeclampsia is a serious task and requires a lot of effort from neonatologists, including their large financial cost too. Every fifth child born to a mother with preeclampsia has impaired physical and psycho-emotional development and high mobility in infancy and early childhood. World Health Organization data. Etiology and pathogenesis of preeclampsia. When we talk about both the pathogenesis and the treatment of preeclampsia with students, I start by saying that the only cause of preeclampsia in pregnancy. This is very important because the only effective treatment method is termination of pregnancy, is delivery. Pregnancy is the only cause of preeclampsia. The main etiological components of preeclampsia in the first placental implantation with abdominal trophoblastic invasion of uterine vessels, immunological maladaptive tolerance between maternal, paternal, or placental and fetus tissues. In the third, maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. In the fourth, genetic factors including inherited predisposing genes and epigenetic influences. In modern obstetrics, it's important to remember that preeclampsia refers to so-called great obstetrical syndromes. For the first time, Giancarlo Di Renzo and Roberto Romero spoke about these syndromes. These syndromes are associated with abnormal trophoblastic invasion at the end of the first trimester and at the start of second trimester of pregnancy. Great obstetrical syndromes, pregnancy complication associated with placenta defect, limited remodeling, and obstructive lesions of the myometrial segment of the spiral arteries. Preeclampsia, fetal growth restriction retardation, intrauterine fetal death, placental abruption, premature birth, premature rupture of the membranes, and miscarriage. They are great obstetrical syndromes. Normal implantation is characterized by intensive remodeling of spiral arterioles within the decidual basals. Endovascular trophoblasts replace the vascular endothelial and muscular linings to enlarge the vessel's diameter. The veins are invaded only superficially. In some cases of preeclampsia, however, there may be incomplete trophoblastic invasion with decidual vessels, but not myometrial vessels, become lined with endovascular trophoblasts. The deeper myometrial arterioles do not lose their endothelial lining and muscle elastic tissue, and the mean external diameter is only half that of corresponding vessels in normal placenta, in normal pregnancy. A schematic representation of normal placenta implantation shows proliferation of extravillous trophoblasts from an anchoring villus. These trophoblasts invade the decidua and extend into the walls of the spiral arteriole to replace to endothelium and muscular wall to create a dilated low-resistance vessel. With preeclampsia, there is a defective implantation characterized by incomplete invasion of the spiral arteriole wall by extravillous trophoblast. This results in a small caliber vessel with high resistance to flow. These physiological changes are required for successful pregnancy. During early human pregnancy, extravillous cytotrophoblast from anchoring villi invade the endometrium and myometrium. Interstitial trophoblast and migrate in retrograde direction along the spiral arteries. This physical transformation is characterized by gradual loss of the normal muscle elastic structure of the arterial wall and replacement by amorphous fibrinoid material in which trophoblast cells are embedded. Failure of trophoblast invasion, note, is very important. Failure of trophoblast invasion and spiral artery transformation has been documented in preeclampsia. Defective placentation is posited to further cause be susceptible pregnant woman to develop gestational hypertension, the preeclampsia, preterm delivery, growth restricted fetus, maybe placental abruption. For example, uterus on the slide, uterus with placenta patient with severe hypertension and intrauterine growth restriction, as in the A, arteries, spiral arteries in the center of the placental bed with complete transformation of the decidual and myometrial segment. B, spiral arteries overlying placental infarction show acute atherosis and intimal hyperplasia in the untransformed segment of the myometrium. Second component, immunological component of pathogenesis of preeclampsia, maternal immune tolerance to paternally derived placenta and fetal antigens. Loss of this tolerance, or perhaps its dysregulation, is another theory cites to account for preeclampsia syndrome. Certainly, the histological changes at the maternal placenta interface are suggestive of acute graft rejection. Some of these factors possibly associated with dysregulation include immunization from previous pregnancies, some inherited human leukocyte antigen, HLA, and NK cell, natural killer cell receptor haplotypes, and possibly shared susceptibility genes with diabetes and hypertension. Main components of the pathogenesis: in the first, generalized spasm of microvasculature and impaired microcirculation, hypovolemia, hyperproteinemia, dysproteinemia, violation of the rheological properties of blood, development so-called chronic form of DIC syndrome, development of multiple organ failure, maybe functional, in most cases functional failure, dysfunction, violation of the uteroplacental circulation, and development so-called placental insufficiency, and intrauterine growth restriction. Kidney changes, edema or glomeruloendothelial cells, glomerulocapillary endotheliosis, narrowing the obturation of capillaries. In 30% of cases, there are glomeruli that haven't been functioning for a long time, closed, and occur increased permeability of the vascular wall and the development of albuminuria. The appearance of Helen casts in the urine, hyperuricemia. Almost of blood showing through the glomerulus decreased, and histotoxic hypoxia. As a result, the renal parenchyma is damaged up to necrosis. Acute renal failure clinically manifested in the form of oliguria and then anuria. Liver changes, decreased blood flow leads to impaired liver function. Several function, protein synthesizing, detoxification, parenchymal and fatty degeneration, acute liver failure, acute fatty liver. For preeclampsia, the following liver changes are typical: necrosis, hemorrhage. Necrosis can be small focal and large focal, single, multiple, sometimes merged, clinically manifested as pain in the right hypochondrium. Liver rupture, very rare. Cerebral changes, dysfunction of the sympathoadrenal system, dysfunction of the sympathetic pituitary system, vasospasm, hypovolemia, DIC syndrome. Thus, there is violation of intracranial homeostasis, morphological changes in the brain, vascular thrombosis, softening, dystopia up to necrosis in the cerebral cortex and other parts of the central nervous systems. hemorrhages of various sizes in the parenchyma, in the ventricles, in the chemispheres, in the white matter, in the visual hillocks, that's in all structures of brain. Effects of preeclampsia of the fetus and offspring. Vascular effects, cardiac effects, hypertension, abdominal arterial dilation, arterial thickening, reduced microvascular density, reduced vasculogenic capacity, cardiac effects, increased left ventricle wall thickness, reduced left ventricle and diastolic volume, reduced left ventricle global peak systolic longitudinal strain, adverse fetal outcomes, fetal hypoxia, premature birth, placental abruption, fetal death. And in the beginning, dysfunctional placentation, inflammation, oxidative stress, hypoperfusion placenta, chronic placental ischemia, increased resistance to placental flow. Diagnosis of preeclampsia. A summary of principal risk factors for preeclampsia: height risk factors, moderate risk factors, young and nulliparous women with particularly vulnerable to development preeclampsia, whereas older women are at greater risk for chronic hypertension with superimposed preeclampsia. The incidents are markedly influenced by race and ethnicity, and thus by genetic predisposition. By way of example, is nearly 2,400 nulliparous enrolled in a maternal fetal medicine units network study. The incidence of preeclampsia was 5% in white, 9% in Hispanic, and 11% in African American women. Other factors include environmental, socio-economic, and even seasonal influences. Incidence of preeclampsia of nulliparous population ranges from 3 to 10%. The incidence of preeclampsia in multiparous is variable, but is less than that for nulliparous. Specifically, population studies from Australia, Canada, Denmark, Scotland, Sweden, an incidence of 1.4 to 4.5%. There are several other risks associated with preeclampsia. These include obesity, multifetal gestation, maternal age, hyperhomocysteine, metabolic syndrome. The relationship between maternal weight and the risk of preeclampsia is progressive, is increased from 4.3% for women with the body mass index less than 20 kg per square meter to 13.3% in whose with the BMI more than 35 kg per square meter. In women with the twin gestation, compared in the those with singleton, the incidence of gestational hypertension 13 versus 6%, and the incidence of preeclampsia 13 versus 5% are both significantly increased. It's interesting that this latter incidence is unrelated to zygosity. A woman with preeclampsia in the first pregnancy are at greater risk in a second pregnancy compared with women normotensive during the first pregnancy, and conversely, in the woman who was normotensive during her first pregnancy, the incidence of preeclampsia in a subsequent pregnancy much lower than the first pregnancy. Also, smoking during pregnancy causes various adverse pregnancy outcome. Ironically, it has consistently been associated with the reduced risk for hypertension during pregnancy. This slide is very important. Criteria for the diagnosis of preeclampsia. There are two types, two degrees of preeclampsia, mild and severe. Mild only two main symptoms: arterial hypertension and proteinuria. Arterial hypertension, systolic BP more than 140 mm, or diastolic blood pressure more than 90 mm up to 20 weeks in a woman with a history of normal blood pressure. Note is very important: two occasions 6 hours apart. Plus proteinuria. Proteinuria more than 0.3 gram per 24-hour sample. And severe preeclampsia, BP more than severe arterial hypertension, blood pressure more than 160 to 100 mm, to occasion at least 6 hours apart, and proteinuria more than 5 gram per day per 24-hour sample, or 3 gram in separate portions of urine. Oliguria, pulmonary edema or respiratory failure, cyanosis, epigastric or right upper quadrant pain, hypochondrium, worsening in liver function, liver failure, cerebral disorders, headache, impaired consciousness, blurred vision, thrombocytopenia, and so-called early or onset preeclampsia, onset before 32-34 weeks. Diagnosis of severe preeclampsia: two main criteria for severe degree, or one main criterion of any degree and an additional criterion 3 to 8. And I repeat, this slide is very important criteria for the diagnosis of preeclampsia. I would like to draw your attention to the fact that preeclampsia is always a serious complication, and preeclampsia can be bad and very bad. Bad, mild preeclampsia; very bad, severe preeclampsia. When we talk about the treatment of preeclampsia, on the most serious issues of the underestimation of the severity of preeclampsia. When a patient arrives with the blood pressure of 140 to 90 millimeters, we can compare the clinic of mild preeclampsia with this little bear. But after few hours, multiple organ dysfunction or failure develops. We say that we notice this huge, dangerous bear out of time, unfortunately. Note that proteinuria, the gold standard of determination of proteinuria, is quantification of protein in a daily portion, 24 hours. 0.3 gram is a limit of norm of daily proteinuria. There are moderate or mild and severe proteinuria. Moderate proteinuria is mild preeclampsia, severe preeclampsia. In the presence of critical symptoms, severe hypertension, thrombocytopenia, cerebral, renal, hepatic dysfunction, maybe failure, pulmonary edema, the presence of proteinuria isn't necessary for the diagnosis of severe preeclampsia. And to assess the true level of proteinuria, it's necessary to exclude the presence of the urinary tract infection. Earlier we talked about the classic triad of signs of preeclampsia, but now more and more we observe the bisymptomatic or maybe monosymptomatic, just only hypertension cause of preeclampsia, when three classic symptoms of preeclampsia are absent. The Zangemeister triad is currently found in only 30%. Isolated edema is no diagnostic criterion for preeclampsia. Moderate edema observed in 80% of women with physiological pregnancy, and note that overdiagnosis of edema syndrome, too many hospitalizations, unseen interventions with unproven efficacy or even dangerous for the mothers and fetus, and outpatient management in safe for isolated edema. But severe edema is very important signs of pregnancy, of preeclampsia. Severe edema in young nullipara with antepartum preeclampsia. Massive rapidly growing edema generalized from the edema form of edema with subcutaneous tissue swelling throughout the body, anasarca, hydrotorix, and hydropericardium are unfavorable prognostic criteria for the severe preeclampsia. Symptoms that indicate a critical situation. Please note that we must pay close attention to these symptoms because they precede the onset of convulsive symptom and onset of eclampsia. Please note that we must pay close attention to these symptoms because they precede the onset of convulsive syndrome or seizures syndrome of the onset of eclampsia. Chest pain, dyspnea, pulmonary edema, thrombocytopenia, increased levels of alanine aminotransferase, aspartate aminotransferase, lactate dehydrogenase, HELP syndrome, creatinine level more than 90 millimole per liter, diastolic blood pressure more than 1 and 10 millimeter, vaginal bleeding, any volume, and convulsions. Convulsions is eclampsia. The symptoms I listed precede the one said the preeclampsia. What's eclampsia? From the Greek, lighting of flesh. Convulsions or seizures and a series of seizures in a pregnant woman with preeclampsia that cannot be explained by other causes. Maybe epilepsy, stroke, brain tumor, etc. Clinical forms of eclampsia: isolated seizures, a series of seizures, eclamptic status, and coma. Symptoms prior to eclampsia: headache, dizziness, general weakness, visual impairment, flashing flies, short and fog, maybe blindness, pain in a bigastric region and right hypochondrium, girdle pain due to hemorrhage in the roots of the spinal cord or Hausen symptom, hyperreflexia, and dilated pupils, angiomastia symptom. An attack of eclampsia consists of 4 successive stages. In the first, small fibrillar twitching in the facial muscles with further spread to the upper limbs. It doesn't not happen with epilepsy. In the second, tonic contractions of the skeletal muscles, loss of consciousness, apnea, cyanosis, bite of the tongue, listening up to 30 seconds. In the third, clonical convulsions extending to the lower extremities, and in the end, take a deep breath, restore breathing and consciousness, amnesia, maybe coma. In some cases, it's necessary to carry out different diagnoses between an attack of eclampsia and an extragenital pathology, not related to pregnancy, which can also manifest itself as a convulsive syndrome. These are diseases such as vascular disease of the central nervous system, ischemic hemorrhagic stroke, aneurysm, intracerebral hemorrhage, vein thrombosis of the cerebral vessels, brain tumors and abscesses, arteriovenous malformations, maybe infections of central nervous system, epilepsy, the action of drugs, hyponatremia, kalemia, thrombotic purpura, post-puncture syndrome, and intoxication. Occurrence of seizures: almost half of all cases of eclampsia occur during pregnancy, 20 before the 31 week of pregnancy. The full-term pregnancy eclampsia in 75%, during childbirth or within 6 hours after childbirth, and eclampsia occurs between 48 hours and 4 weeks postpartum in 16 of cases. Now we will talk about one of the obvious complication of preeclampsia and eclampsia. HELP syndrome is a serious complication of pregnancy characterized by chemolysis, elevated liver enzymes, and low platelet count. The term HELP syndrome is composed of the first letters of the main symptoms HELP. HELP occurring in 0.5 to 0.9% of all pregnancies and in 10 to 20% of cases with severe preeclampsia. HELP syndrome occurs in 31% cases before and in 69% after childbirth. The main links of pathogenesis: autoimmune mechanism of endothelial damage, hypovolemia with hemoconcentration and formation of microthrombosis with subsequent activation of fibrinolysis, increased platelet aggregation and destruction, large amounts of thromboxane, generalized vasospasm and ischemic necrosis in all organs, including of the liver, and antiphospholipid and antiplatelet antibodies formed during HELP syndrome, as well as immune complexes that clog the hepatic sinuses and cause liver damage. Diagnostic: in 90% of patients, the onset of the disease is characterized by pain in the epigastrium or right hypochondrium. The pain in the right hypochondrium is associated with edema and enlargement of the liver. Half of patients also experience nausea and vomiting. Proteinuria and hypertension in 20 or to 30% of cases are mild or absent. With advanced HELP syndrome, vomiting of blood, hemorrhages in the injection sites, jaundice and liver failure are observed. Complication of HELP: disseminated intravascular coagulation, DIC syndrome 21%, placental abruption, renal failure, pulmonary edema, subcapsular hematomas and liver ruptures, and retinal detachment. Treatment principles: one of the major authoritative guidelines for obstetrics, Grazin-Reznik's maternal fetal medicine principles and practice, says that hemorrhages and preeclampsia, not preeclampsia, present high opportunities for preventability. Pulmonary embolism, sepsis, cardiomyopathy are intermediate, and death from amniotic fluid embolism were deemed unpreventable. Preeclampsia, high opportunities for preventability. It's very important. It's very important to remember that treatment for preeclampsia is based on these three main components: anticonvulsant therapy, termination of pregnancy or delivery, or antihypertensive therapy. Firstly, we must decide on the timing and method of delivery. I will talk about this a little later. Secondly, in case of severe preeclampsia, we carry out prophylaxis of convulsive syndrome or seizures with magnesium sulfate. And thirdly, antihypertensive therapy is very important. There are several groups of drugs which I will also talk about later. I have already said that the main cause of preeclampsia is pregnancy. It follows that the only effective treatment for preeclampsia is termination of pregnancy. Termination of pregnancy is the only effective method of treating preeclampsia. Note and remember it. In order to talk about the timing and method of delivery, one should recall the classification of preeclampsia according to the severity. I show this slide again. Only two types: preeclampsia, mild and severe, two main symptoms: arterial hypertension and proteinuria, and several little criteria. If we observe moderate preeclampsia, mild preeclampsia, then it's possible to prolong pregnancy up to 36 weeks. In this case of severe preeclampsia, delivery in most cases after the prevention of respiratory distress syndrome. If you diagnose this preeclampsia before 24 weeks, then it's always severe preeclampsia and it's necessary to terminate a life-threatening pregnancy. In the 25 to 27 weeks, it's possible to prolong pregnancy to delayed of delivery in the absence of life-threatening symptoms. At the same time, we carry out the prevention of fetal respiratory distress syndrome by glucocorticoids. For severe preeclampsia after 28 weeks, in most cases, we deliver the patient within the first 24 hours after diagnosis, severe preeclampsia after prophylaxis of respiratory distress syndrome. This slide very important. Management of preeclampsia depends on term of pregnancies and degree of preeclampsia. For severe preeclampsia, delivery after 34 weeks. For mild preeclampsia, delivery at full-term pregnancy, 37 weeks. Full-term pregnancy and preeclampsia should not be combined. Do not prolong pregnancy delivery depending on the obstetrical situation. When we talk about obstetrical situation, we mean the following conditions. Indication for emergency delivery, several minutes, only 2 indications, bleeding from the vagina, suspected placental abruption, and fetal hypoxia, acute fetal hypoxia after 22 weeks of gestation. Indications for urgent delivery, several hours, persistent headache and visual disturbances, persistent epigastric pain, nausea and vomiting, progressive deterioration of liver function, liver and or kidney failure, eclampsia, arterial hypertension, not amenable to drug correction, the platelet count is less than 100 and its progressive decrease, and violation of the fetus according to cardiotocography and ultrasound. In all these cases, the pregnant woman must be in the intensive care unit, will stabilize her condition and prepare to delivery, maybe vaginal delivery, maybe C-section. Vaginal delivery should be considered in all cases of preeclampsia, including severe preeclampsia, in the absence of absolute indications for C-section and satisfactory fetal condition. Schematic clinical management algorithm for suspected severe preeclampsia before 34 weeks. Severe preeclampsia, admit to labor and delivery, maternal and fetal assessment, consider magnesium sulfate, treat dangerous hypertension, contraindication to conservative management, persistent symptoms of severe hypertension, eclampsia, pulmonary edema, help, significant renal dysfunction, coagulopathy, placental abruption, prevable fetus, fetal compromise. If these conditions are present, deliver. If absent, initial 24, maybe 48-hour observation, corticosteroid for lung maturation of fetus, frequent evaluation, vital signs, urine output, daily lab evaluation for HELP syndrome, develop contraindication, deliver. Ongoing inpatient management, daily maternal assessment, serial lab evaluation of renal function, and for HELP syndrome, daily fetal assessment and evaluation of serial growth and amniotic fluid volume, and deliver at 34 weeks. Severe preeclampsia. Note, term of pregnancy, severe preeclampsia, deliver at 34 weeks. If we make decisions about vaginal delivery in this case, we must follow these principles for labor management in preeclampsia. And the first is very main principle: maximum pain relief with epidural anesthesia, because pain is a trigger of increase of blood pressure. Early amniotomy before 4 centimeters of dilation of cervix, blood pressure control, continuous blood pressure control, prevention of labor anomalies, internatal fetal care, maybe with oxygen, and application of vacuum extractor ready to apply obstetric forceps in second stage of labor. Prevention of respiratory distress syndrome. From 24 to 34 weeks, we must definitely carry out the prevention of respiratory distress syndrome of the fetus for the maturation for the lungs of the fetus in case of early delivery before 34 weeks. And corticosteroids are prescribed to all patients with preeclampsia in cases where delivery isn't excluded within the next 7 days. In some cases, it's possible to prescribe glucocorticoids after 34 weeks, for example, diabetes mellitus. There are several schemes of prevention schemes of glucocorticoids. We use third schemes, 3 doses of dexamethasone at 8 milligrams intramuscular every 8 hours. Course is 24 hours. The second principle of treatment of patient with preeclampsia is the prevention of convulsive or seizures syndrome. Magnesium sulfate is the first line drug, or maybe only one line drug for the prevention and treatment for seizures in preeclampsia and eclampsia. Magnesium sulfate is administered at an initial dose of 4 grams of dry substance or 16 milliliter of 25% solution for 10 to 15 minutes, then 1 gram per hour, 4 milliliters per hour of 25% solution. Note that in a woman with chronic hypertension or gestational hypertension, magnesium sulfate can be administered for neuroprotection in the fetus up to 34 weeks, and labor is due within the next 24 hours. In case of emergency indication from the mother and fetus, delivery should not be delayed in order to administer magnesium sulfate for neuroprotection in the fetus. In the antenatal period, the appointment of magnesium sulfate should be accompanied by continuous monitoring of the fetal heart rate using cardiotocography. Magnesium sulfate is an anticonvulsant drug, but not an antihypertensive drug, and should not be interrupted on the basis of decrease in blood pressure. And magnesium sulfate is an emergency drug, and its plain use during pregnancy doesn't prevent the development and progression for preeclampsia. Scheme showing the major influences of sympathetic nervous system of physiological determinations of arterial pressure. Bold arrows denote endogenous mechanism leading from central nervous system to maintenance of blood pressure, and dotted arrows show sites in which sympathetic antihypertensive drugs used in pregnancy might exert their effects. We use alpha-2 agonist, methyl-dopa, clonidine, alpha-1 antagonist, for example, prazosin, labetalol, beta-2 receptor mini effects vasodilation, alpha-1 receptor's major effect was a constriction, cardiac B1 receptor chronotropy, inotropy effects, and others. The main groups of drugs for lowering blood pressure are methyl-dopa, beta blockers, and for layered preeclampsia and the presence of chronic arterial hypertension, as well as calcium channel blockers. Main dosage and frequency of administration are shown on the slide. Diuretics for treatment of preeclampsia are rarely used because they additionally cause hypercoagulability and decrease in intravascular volume. On this slide you can see the basic principles of preeclampsia treatment. Timely delivery in the first place. It's also imperative to carry out prophylaxis of convulsive syndrome and severe preeclampsia and antihypertensive therapy. 2 and 3, up to 34 weeks of using glucocorticoids for fetal lung maturation, and very strict limitation of infusion therapy, sensing presence of endotheliosis and decrease in the volume of circulation volume. The use of infusion therapy will lead to pulmonary edema and cerebral edema. Limitation of drug therapy for preeclampsia. The following drugs should not be considered for women with severe preeclampsia and eclampsia until delivery: antipsychotic, fresh frozen plasma, albumin, xanthine, synthetic colloids, antiaggregants, diuretics, narcotic analgesics, and low molecular weight heparin and other anticoagulants. Principles of patient management with eclampsia in the intensive care unit: condition assessment, observation monitoring, blood pressure control, continuous blood pressure control, antihypertensive drug, seizure prevention by magnesium sulfate, prevention of fetal respiratory distress syndrome by corticosteroids, water balance control, deciding of the timing of the delivery, constant vigilance of the postpartum period, and prevention of long-term complication. Principles of patient management with eclampsia in the intensive care unit: monitoring of the main parameters from the mother side and from the side of the fetus side. Blood pressure measurement every 15 minutes until stabilization is achieved, then every 30 minutes. In some situations, after the comprehensive assessment, it's possible to switch the less frequent measurement. Generalized edema, retina, reflexes, convulsions, analysis of all urine samples for protein, diuresis control. From the fetus side, cardiotocography long-term until blood pressure stabilizes continuously during labor, provides information about the conditions of the fetus but doesn't provide information regarding the prognosis. Ultrasound, phytometry, amniotic index, placentimetry, and velocimetry of Dopplerometry, umbilical arteries, middle cerebral arteries. To provide emergency care for eclampsia, you can remember the mnemotic rule ABCCD of eclampsia management: ABC of resuscitation, airway, breathing, circulation. Second C is control seizures by magnesium sulfate. Third C, control hypertension by antihypertensive drugs, for example hydrolysine, maybe methyl-dopa, maybe clonidine, maybe beta blockers, maybe nifedipine. And D, deliver, if not postpartum eclampsia, labor, induction, or C-section. and job aid for management of eclampsia. I talk about it. And a few words about prevention of eclampsia. Only two methods are scientifically proven to prevent preeclampsia. This is use of low doses of acetylsalicylic acid or aspirin, and the use of calcium supplements. In Russia, it's believed that calcium is supplied in sufficient quantities with food. As a result, we are talking about only the use of acetylsalicylic acid. Low dose aspirin is not recommended for primiparous women with a low risk of preeclampsia. When describing aspirin, the woman's writing and informed consent is required, because accordance with the instruction for use, taking aspirin is contraindicated in the first 3 months and after 36 weeks of pregnancy. Pregnant women at high risk of development preeclampsia are advised to low dose aspirin 150, 162 milligram per day, starting 12 weeks before delivery, which improves the depth in placentation and blood flow of the spiral arteries of the uterus. Recommended daily intake 150 milligrams aspirin to all patients at high risk of preeclampsia. Hypertensive disorder during previous pregnancy, history of hypertensive disorders in previous pregnancy, chronic kidney disease, autoimmune disease, systemic lupus erythematosus, antiphospholipid syndrome, diabetes mellitus, maybe type 1, maybe type 2, chronic hypertension. Recommended daily intake for patients with more than one moderate risk factor for preeclampsia, first pregnancy, age 40 and older, the interval between pregnancy intergenerative interval more than 10 years, BMI over 35 kg per square meter, family history of preeclampsia, and multiple pregnancy. Prevention of preeclampsia by acetylsalicylic acid, low dose. Pregnant woman with low calcium intake, less than 600 milligrams per day, administration in the form of calcium supplements at least 1 gram per day. And thanks for attention.